Uh, am I audible?
Oh, yeah, yes, go ahead, please.
Okay. A very good morning to all course directors, chairpersons, and my beloved teachers, colleagues, and friends at Madras Medical Mission. Today, I will talk on anticoagulation management, basically with relation to cath lab practices. So this is a picture of a cath lab where we perform around 300 to 350 odd pediatric cardiac cath and interventions per year. Venous or arterial thrombosis is a well-known adverse effect after cardiac catheterization in children. Moreover, complications related to stent and device-related procedures, although infrequent, may be seen in a few patients. The risk can be substantially reduced by procedural anticoagulation and post-procedural thromboprophylaxis. What are the most common drugs used in cath lab practices? The most commonly used drug is unfractionated heparin, which is indicated for anticoagulation in the cardiac cath lab, as well as cardiac surgery and in treatment of thrombosis or increased risk of thrombosis. Other than that, low molecular weight heparin, which acts as a bridge between heparin and warfarin postoperatively, may be used. Vitamin K antagonists such as warfarin is used usually for long-term anticoagulant therapy. Oral antiplatelet agents such as aspirin and clopidogrel are usually used for thromboprophylaxis of cardiac or vascular devices and stents, as well as in the treatment of Kawasaki disease or MIS. The most common thrombolytic agent used in pediatric cardiac catheterization is alteplase, which is a recombinant tissue plasminogen activator, and it is indicated in arterial thrombosis, pulmonary embolism, deep vessel thrombosis, and coronary thrombosis in Kawasaki disease. It has a variety of doses depending on systemic or catheter-directed installation. So what are the anticoagulation guidelines for the pediatric cardiac catheterization and interventions as laid out by the American Heart Association? In case of cardiac cath with arterial access, unfractionated heparin bolus of 100 units per kg is recommended. In case monitoring is recommended with determination of activated clotting time every 1 hour and thereby every half an hour with additional doses of heparin as required. In case of cardiac cath performed with only venous access, procedural anticoagulation is reasonable if there is a right to left shunt, if the procedure is interventional, or the procedure is expected to be prolonged. We may not use cardiac procedural anticoagulation in case of right heart study or in case of endomyocardial biopsy. In case of endovascular stent implantation in children, post-procedural thromboprophylaxis is done with low-dose aspirin for at least 6 months. In case of PDA stenting, continuous heparin infusion might be continued for a minimum of 12 hours after the procedure, and antiplatelet drugs, dual antiplatelet agents may be started after the initiation of feeding. In case of higher thrombotic risk lesions, such as non-pulsatile flow in PS stenting in Fontan, or in case of stented shunts, it is reasonable to use warfarin or low molecular weight heparin in addition to antiplatelet therapy for 3 to 6 months, followed by antiplatelet therapy alone. We all know the post-procedure prophylaxis for ASD, VSD, and PDA devices. Some important points are that in older patients or those with larger devices, a second antiplatelet agent may be considered in addition to aspirin for 3 to 6 months after implantation. Warfarin anticoagulation may be required in adult patients with atrial arrhythmia, especially atrial fibrillation, and those with other risk factors. If there is a residual defect after device implantation, thromboprophylaxis beyond 6 months may be continued as there is a risk of paradoxical embolus. And in case of PDA device, usually post-procedural thromboprophylaxis is not indicated. VSD device, it may be continued for 6 months. In case of valvuloplasties, balloon pulmonary valvuloplasty has a variable procedure anticoagulation depending on the operator preference, and both BAV as well as balloon angioplasty procedures for vascular structures and aorta require procedure anticoagulation. No specific post-procedural aspirin is required. In case of coil or device closure of abnormal vascular structures, usually no post-procedural aspirin is required except in case of PAVMs with large feeding arteries requiring large occluder devices. Fontan fenestration device closure requires dual antiplatelet for 6 months, after which only aspirin is continued. In case of balloon atrial septostomy, the use of anticoagulation in the procedure depends on the center. We prefer to use a low dose of heparin. In case of A coronary cameral fistula, a post-procedural thromboprophylaxis with aspirin is indicated for at least 6 months, and in case of very large aneurysmal fistula struct may be continued indefinitely. Sometimes post-procedural heparinization for 12 to 20 to 24 hours may be done. In case of valve implantation, transcatheter valve implantation, pulmonary valve, low-dose aspirin may be continued for 6 months to 1 year or lifelong, depending on the institutional practice. Aortic valve implantation requires aspirin lifelong with clopidogrel for 6 months and anticoagulant for at least 3 months. Tricuspid and mitral valve depends on the different trials. In case of PFO device closure, dual antiplatelet therapy with with aspirin and clopidogrel for 6 months is given and continued with a single drug for at least 5 years. In case of LA appendage device closure, dual antiplatelets for 6 weeks followed by aspirin indefinitely is recommended. Now, post-catheterization arterial thrombosis may present with silent vessel occlusion to severe limb ischemia. Venous thrombosis is often subclinical. The clinical implication is the loss of arterial or venous access for future interventions and thus limiting therapeutic options. Doppler ultrasonography may help to detect higher incidence of flow compromise in patients who have undergone previous cardiac catheterization. What are the risk factors? Younger age, longer procedural time, EP study and therapeutic intervention as opposed to diagnostic cath, larger vascular sheath, and patient-related polycythemia or thrombophilia. Prevention by ultrasound-guided access, stepwise predilatation, proper procedural planning, adequate heparinization, and prophylactic antispasmodic therapy. Intraprocedural and post-procedural monitoring of ipsilateral limb oxygen saturation, as well as post-procedural ultrasound, may be helpful for early detection. The AHA recommends that patients with who present with arterial thrombosis should be initially treated with intravenous heparin for 12 to 48 hours, and the dosing and length of therapy should be individualized. If limb ischemia persists, surgical consultation is indicated and it is reasonable to transition to fibrinolytic therapy. However, if fibrinolytic therapy is contraindicated, surgical or transcatheter intervention may be considered. And thrombolysis is particularly a very good option for small children who have a suboptimal outcome with surgery, and hence which may be systemic or catheter-guided. Catheter-guided thrombolysis is frequently being performed in the cath lab for thrombosis of stents and postoperative shunts. And newer anticoagulants are being used on an experimental basis. Low-dose altiplase may be an effective option with increased safety margins. So this is an example of a 2-year-old girl who underwent declension for single ventricle physiology. There's a persistent desaturation post-operatively. Cardiac cath was done, which suggested occluding thrombus in the PA confluence, and no LPA flows were seen. So we started on continuous heparin infusion, catheter-directed thrombolysis using injection altiplase at the rate of 0.5 mg per kg stat, followed by 0.1 mg per kg per hour for 2 hours was done from the right internal jugular venous sheath. Flow in the distal LPA was seen after the procedure, and the heparin infusion was continued for 5 days, followed by warfarin in therapeutic doses. And on workup later, the child was diagnosed with protein C and S deficiency. So these are the echo pictures, which the left one shows the echo prior to thrombolysis, and the right one shows the echo on follow-up where good flows into the LPA may be appreciated. So this is another case which has been given to me by my colleagues at Narayan Super Specialty Hospital. This is a 19-day-old male baby who underwent successful PDA stenting for single ventricle pulmonary atresia. There was sudden desaturation while shifting. The angio revealed stent thrombosis with poor flows into the branch PAs. So anticoagulation with heparin was started and thrombosuction was attempted. And finally, catheter-directed thrombolysis into the stent was done with a glycoprotein 2B3A inhibitor, which is eptifibatide. And post-thrombolysis, good flows across the stent into the branch PAs were seen. So to summarize, vascular complications, predominantly arterial and venous thrombosis, are frequently seen in pediatric cardiac catheterization, both for diagnostic and therapeutic purposes. Such complications can be prevented to a great extent by procedural anticoagulation. Post-procedural thromboprophylaxis helps to prevent the thrombotic complications associated with therapeutic interventions. Catheter-directed thrombolysis is emerging as a treatment of choice for inadvertent acute thrombosis of shunts, stents, and vascular structure. Thank you, and in advance, a happy Diwali from the Mission Hospital, Durgapur.